Good afternoon, everyone. Thank you for joining us for today's State Peer-to-Peer Learning Session, Innovative Post-Crisis Follow-Up Procedures. Before we begin, I'd like to review a few housekeeping items. As you come in, please add your name and what state you're from in the chat. Due to the high number of participants on this call, all participant lines will be muted for the duration of the session. If you have any comments or questions, please submit them at any time by using the chat feature. CART services are also available. You can view the captions in your browser by clicking the link in the chat, or depending on your screen size, you can go to the ellipsis at the bottom of your screen below More to show captions and change the size, or use the caret beside the closed caption notation at the bottom of your screen. If you experience any technical issues during the webinar today, please message us using the chat feature, which is located at the bottom center of your screen, or email us at jenny.house@nashbid.org. Lastly, this is a recorded event, and your participation grants you consent to be recorded. It is now my pleasure to turn the call over to Dr. Brian Sims, Senior Medical Advisor at NASHBID.
Thank you so much, Bailey, and good afternoon to everyone, and welcome to today's presentation of the State Peer-to-Peer Learning Session entitled Innovative Post-Crisis Follow-Up Procedures. I want to first of all thank you for joining us for these important presentations that are going to be focusing on post-crisis follow-up and its critical role in strengthening behavioral health crisis systems and improving outcomes for individuals who may be experiencing mental health and substance use crises. My name is Dr. Brian Sims. I am a Senior Medical Advisor with the National Association of State Mental Health Program Directors, and it is my privilege to welcome you and serve as moderator for today's session. I would also like to express our sincere appreciation to the Substance Abuse and Mental Health Services Administration, or SAMHSA, for sponsoring this event and for its continued leadership in advancing crisis care nationwide. Through its commitment to comprehensive person-centered crisis response systems, SAMHSA has helped communities build pathways to recovery, resilience, and hope for individuals and families affected by behavioral health challenges. I would also like to thank each one of you for what we trust will be a discussion with information that you'll be able to take away that will enhance your respective deliveries of care. Now, we're aware that the crisis systems continue to evolve, as we've seen in initiatives that have come up over the past years, such as the 988 Suicide and Crisis Lifeline, the mobile crisis response teams, our crisis stabilization programs, and expanded community-based services. In all of these, we've learned one important lesson. Effective crisis care does not end when the immediate emergency is resolved. In many ways, the period following the crisis represents one of the most important opportunities for our engagement, recovery, and prevention. Post-crisis follow-up serves several critical purposes and highlights what we will be talking about and the states will be giving us information on later. One of the things that they highlight is maintaining connection during periods of heightened vulnerability. They help to support the continuity of care and successful linkage to treatment and community services. They reinforce safety plans and recovery goals that may have been established during the crisis intervention. They reduce the likelihood of repeat emergency room department visits, psychiatric hospitalizations or rehospitalizations, and future crises. And they demonstrate to individuals and family that they do not have to navigate recovery. Now, community post-crisis follow-up is a vital component of recovery and resilience building. After a crisis has passed, communities require continued support to address remaining needs, to restore that trust, and strengthen the social connections. Now, effective follow-up allows community leaders as well as organizations to evaluate the response efforts, to provide ongoing assistance, and apply lessons learned to improve preparedness for future emergencies. Now, by maintaining that engagement and the support, individuals can recover more readily and effectively and emerge stronger from challenging events. Now, going to today's session, we will be led by 3 states that will be exploring the evidence supporting post-crisis follow-up interventions. They will display some of their best practices for outreach and engagement following a behavioral health crisis. They'll give us strategies for integrating those follow-up services into state and local crisis systems. They will provide opportunities for improvement of the continuity of care and recovery-oriented outcomes, and share with us some lessons possibly learned from jurisdictions that have already successfully implemented these innovative follow-up models. So I'm honored today to not only moderate this session, because it's going to feature a number of wonderful state leaders from the great states of Illinois, Mississippi, and Utah. Each of these states have developed distinct approaches to post-crisis follow-up that will leverage that cross-sector collaboration, that will talk about data-informed decision-making, targeted intervention strategies, and strong accountability frameworks. Now, as each state presents their respective initiatives, we'll be able to better understand how some state governments are addressing gaps in post-crisis support, how they're measuring effectiveness, and scaling practices that improve both the individual well-being and the public sector performance. So the experiences you're about to hear from Illinois, Mississippi, and Utah will hopefully offer valuable insights into how policy innovations can transform crisis response from a singular event into a comprehensive continuum of care. As I said, I'm honored to be your moderator for this outstanding cluster of states who are going to explain their innovative post-crisis follow-up strategies. The states, as I mentioned, are Illinois, Mississippi, and Utah. And I would like to take this opportunity to personally thank these states for their willingness to share their wonderful work with us in this space. And with that, we are fortunate to be joined by an exceptional group of state leaders. Our first presenter will be Ali Lichterman, who is a community programs administrator with the Illinois Division of Behavioral Health and Recovery. She will then be followed by Wendy Bailey, who is the executive director of the Mississippi Department of Mental Health. We will then be followed with a presentation from Utah from Jennifer Hebden Seljestad, who is a crisis programs administrator with the Utah Office of Substance Use and Mental Health. And she will be joined with Teresa Lopez, Director of Behavioral Health Integration with the Huntsman Mental Health Institute in Utah. So I want to thank you all in advance for sharing your expertise and experiences with us today. And with that, I'm pleased to turn over our discussion to the first presenter, Ali Lichterman from Illinois. So Ali, please go ahead.
Thank you so much. Hi, my name is Ali Lichterman, and as was shared, I'm the Crisis Community Programs Administrator for the Illinois Department of Human Services, Division of Behavioral Health and Recovery. So I oversee both grant funding and policy around our behavioral health crisis continuum, 988 crisis response living rooms, and crisis residential. And really excited to be here to talk with you all a bit about how we're working to make sure that our follow-up services can be funded sustainably while also giving our providers the flexibility they need to provide really care that centers around the individual in crisis. So next slide, please. I'm going to start with a quick overview of how our system in Illinois works. Next slide. Thank you. So as in many places, our crisis system in Illinois, and I saw many Illinoisans in the chat and some of our providers, so they're very familiar with this. Our system is fractured. across our mental health authority, the Department of Human Services, where I work, and our Medicaid authority, Health and Family Services. Both agencies have programs across all three crisis pillars that include a 24/7 crisis line and 24/7 mobile crisis response, and there's minimal interaction between these services. Additionally, here at DHS, we're required by state law to make our mobile crisis response and 988 accessible statewide through 911 by July 1, 2027. So a lot of moving pieces, a lot of work to get those in need, the behavioral health crisis services that are often the right resource in that moment of high need. And this fracturing means that there's often a confusing experience for individuals seeking care, increased administrative burden for our providers, including difficulty billing for and sustainably funding follow-up services, and grant spending on potentially Medicaid eligible services so that we're not maximizing our dollars and that federal match. Next slide. Our agencies take very different approaches to funding our behavioral health crisis services, including follow-up, and that can really impact what services can be provided and how flexible they can be and how focused on the individual in crisis they can be. So for our Medicaid authority, HFS, it's all event-based Medicaid funding, which means that you need to, for every bit of that interaction, be figuring out what code does this fit into, and that includes follow-up services, which again is what codes does this fit into sometimes, rather than what exactly is needed and what maybe creative follow-up and continued follow-up and length of follow-up is needed for this person in particular. So while this can limit service flexibility, it does mean that we can really maximize Medicaid contribution, and it has a really sustainable, strong funding source to make sure that while there's more limited flexibility, it's a program that can be scaled and that isn't going anywhere. At DHS, our services are grant funded and we're paying for capacity with very minimal Medicaid billing. And what's in our grant from previous years doesn't always totally line up with what is Medicaid billable. So that means that we are often using grant funds for services that could ideally be Medicaid funded, get that federal match, and then open those dollars up for unfunded individuals or other services that aren't Medicaid eligible. So this means that while we are challenged on the funding front, we have a lot of flexibility to meet the needs of the individual if they need multiple days of follow-up, and that's allowable without significant burden because it's a capacity grant rather than events-based. Next slide, please. So to put these pieces together, our current model on the DBHR side is reliant on grant dollars and more flexible. On the Medicaid side is more stable funding, but less flexible. And overall, this is inhibiting system growth. It can be burdensome for our providers and doesn't give us the ability to encourage that maximization of federal dollars to provide robust care and especially follow-up care for individuals after the crisis incident when we're trying to build a system that's sustainable, scalable, equitable, and really focused on the needs of that individual in crisis and getting them what's best for them every time. Next slide, please. So how are we approaching solving this problem? We're looking at mobile response and stabilization services, which may be a phrase that you've heard other places, and we are also now using in Illinois. Next slide, please. So we're working to unify our mobile crisis response infrastructure, starting with our programmatic expectations and our funding source. And we're doing that by building out mobile response and stabilization services, or MRSS, which is a new bundled Medicaid code. This code covers the day of crisis plus 72 hours. It's a bundled rate meant to encompass all the work that could be happening in that time period. And our grant requirements are aligned with what's in this code to make sure that what we're asking our grant-based providers to do could also be billed. And that also means that there's going to be some programmatic shifts for providers that are primarily working with each department. The attempt is to move us towards a more consistent crisis system without changing too much at once, right? Like how calls are dispatched, process for becoming a provider. Most elements aren't changing. We are focusing on billing and parts of our programmatic requirements. And for the purposes of this conversation, want to focus on how this is going to make it easier for follow-up, because it's up to 72 hours under that Medicaid billing code, but our grant still exists, and that includes follow-up for up to 30 days. I will also say the code can be used again if after that 72 hours another crisis is initiated. This is very much still a work in progress. We're getting close to launch. The change has been announced to our providers, and we've been working really hard to be communicative with all of our stakeholders and meeting monthly and answering questions. And again, we are coming to you with updates from the middle of this process, and want to give a shout out to our providers for working with us through these changes, and to our partners at Health and Family Services. None of this would be possible without dedication from all involved, and our leadership has been meeting from our two departments in person monthly for many months to really get into the details of how can we make this work to, again, move towards a more sustainable, scalable, equitable model. And that relational building has really made a huge difference. And we'll also use this minute to say I am not from the Medicaid Authority, so we'll do my best to answer questions or connect with them if folks have more specific questions about that element. Next slide, please. So in effect, the hope is that, or not the hope, what we are going to make happen is that our staff can move from focusing on billing to really focusing on the individual in crisis, and at the same time leverage Medicaid dollars more effectively. This still is certainly a big transition that requires a lot of work with our providers to make it happen and to get to that stage of really having a much lighter administrative burden. And want to shout out all of our providers who I see in the room. And FY25, our DBHR funded teams around the state provided over 25,000 mobile responses. And everything we're doing is to make sure that that keeps growing, not only for the initial response, but for the follow-up, to hopefully prevent that person from needing the service in the future and instead be connected with the long-term care they need. Next slide, please. Yeah, so I'm happy to answer any additional questions. Here's my contact information. And with that, I will throw it over to Mississippi.
Thank you very much. In Mississippi, we have measured progress on our crisis system, but also it's something that we're working to build into how our system functions every day. So one of the ways that we've done that is by focusing on a clear, connected approach to crisis care and ensuring that follow-up care is provided within all aspects of the continuum. Next slide. So we have been very intentional about building a crisis continuum that meets people wherever they are, because we know that a behavioral health crisis does not always look the same for everyone, and it doesn't happen at just one point in time. And just as importantly, after that immediate crisis has passed, Mississippians need someone to follow up, someone who will stay connected, someone who can help navigate next steps, and who can support long-term stability. So what we've worked to build in Mississippi is a system that recognizes all of those needs and responds to each one of them. A system where services are not operating in isolation, but are connected to one another, so that no matter how someone enters crisis care, they are not starting over at each step. Instead, they're being guided through a continuum, and one that lasts after they've left the crisis system as well. So that means having stronger connections between our 988 call centers, our mobile crisis response teams, our crisis stabilization and crisis residential services, our state hospitals level of care if needed, and then ongoing community-based care. But that also means having stronger follow-up procedures. Next slide. So I want to walk everyone through what post-crisis follow-up looks like in our state. Every single day, there are trained counselors sitting in our 988 call centers answering the phone when someone's experiencing one of the most difficult moments in their life. And in Mississippi, they're not just call takers, just like in your states as well. They are listeners, they're de-escalators, and they're connectors. And they bring that passion and patience and skill to every interaction and every phone call that they take. And the impact of that work is very real. In Mississippi, we have 2 call centers answering the state's calls: Contact the Crisis Line and Contact Helpline. And yes, I am biased, but I think we have the 2 best call centers in the United States. More and more Mississippians are reaching out to our 988 centers, and more importantly, they're getting connected to someone who can help. So we are continuing to see an increase, approximately about 20% in the number of calls each year. And we remain in the top 10 for our in-state answer rates in the nation. And I think we also, if it was measured nationally, would be in the top for our follow-up as well. And that tells us 2 things: that people are becoming more aware of where to turn, and that they trust that someone's going to be on the other end of the line. But a strong system doesn't stop at answering the call. So our focus now and moving forward is on what happens next. So we have a 988 follow-up program design. And what that means is follow-up calls from 988 begin within 24 to 48 hours after receiving a referral from a crisis line worker. And then each case is assigned to a trained staff member who makes that initial contact. And then additional follow-up calls can be tailored to the needs that are assessed during the first interaction, because every person is unique and different, and so are their needs. So an initial contact call as follow-up from 988 occurs within 24 to 48 hours post-referral. A second contact call is made 3 days after the initial call, and the third contact call is made 7 days after the initial call. Further calls would depend on the client's needs. And clients also know that they can initiate contact with 988 at any time. They don't have to wait on that follow-up call. We document all our 988 call centers, document all calls in a program that we have in Mississippi called iCarol. So it details this established safety plan. It has a call summary and current risk levels. So then when follow-up occurs, the individual providing the follow-up has access to this system, and they can see those parts of the system for that individual. The follow-up calls employ active listening to engage the caller, to provide support, and then to explore options for that caller. We have a maximum of 3 unsuccessful call attempts that would be made within 24 hours before the client is assumed to no longer wish to participate in the follow-up program. And this program is designed to take place again within the week following the initial crisis call, and it does not extend beyond 1 month. The goal of the 988 follow-up program is to reduce relapse rates and the need for serious interventions such as hospitalization. We strive to provide a supportive and a non-judgmental environment that encourages recovery. And I think our call centers do a fantastic job of that. But again, all of this is about building a crisis continuum that doesn't just respond, but responds well. So a system where people are met with that compassion and calls and services are coordinated and no one falls through the cracks after that first call. But at the end of the day, it's about making sure that someone who reaches out for help knows that someone is there, and that connection leads to real support and to that continued services. So we have community mental health centers in our state that provide what's next on your slides: the peers follow-up, the mobile crisis team, and some peer respite services as well. When a community mental health center is made aware that someone has contacted 988 and contact information is available, they place an immediate call to that person. It could be by a peer, a therapist, or any other community mental health center staff member to support the person, offer local services at various options, offer a mobile crisis response if needed, offer an appointment with a staff member at the county office, or possibly a referral to a crisis stabilization, whatever is needed for that individual. If someone does need a mobile crisis response, so if someone calls 988, but they still need someone to come out for a physical face-to-face response, if someone needs that mobile crisis response, a follow-up is completed by the community mental health center within 24 hours by an appropriate staff member. Mobile crisis team members can conduct the follow-up. However, if the person has an established relationship with another staff member, let's say they already have a therapist or a community support specialist or a peer support specialist, that follow-up can be done by them as well. So the purpose of the follow-up for mobile crisis is to ensure that the crisis has been resolved or is at least decreasing in severity. The crisis safety plan that was developed is solid and is being followed through, and that the person is working on following through with the services if they so choose to do. Again, it's important to assist with any barriers to receiving services that might arise, and that is done in that follow-up care. We also have caring contact cards that many of our community mental health centers use that are mailed to a person within 7 days. And that just adds that personal touch to the follow-up. There's a database of crisis calls that are kept so that it can be easily assessed to determine the details of the crisis event. You can look to see who provided the follow-up, what type of follow-up was done, if a caring contact card was mailed, what follow-up services were scheduled. And again, this is to ensure that no one in a crisis falls through the cracks. So I want to give you 2 examples of just some pretty recent follow-up situations that we feel is why it's so very important, especially with mobile crisis, that follow-up care is happening. There was a student at a local college here in Mississippi that was involved in a crisis situation where mobile crisis response responded on a Thursday evening. The student was not in an immediate risk of danger to theirself or others, but they were placed on a safety plan with their roommate. The very next morning, a peer support specialist who worked for the community mental health center reached out to the individual to provide that follow-up care. The student was kind of reluctant to agree to engage in services the night before when mobile crisis responded, but that next morning, when they had a little more clarity in the next day and they weren't in that active crisis, the peer support specialist who provided that follow-up care was able to encourage the student and be present with them step by step through the process of receiving services. The peer support specialist scheduled the appointment for them, met the person in the parking lot of the community mental health center, and guided him through the intake process, which I think all of us on this call knows can be very overwhelming, an intake process. So without that follow-up by that peer specialist, that student may have never agreed to receive services. And that may have ended that experience after that mobile crisis response. There was also recently an individual that had been involved in a crisis, again, requiring that mobile crisis response. And that person was not in immediate risk of danger, but the following day, the person's therapist contacted them. So they established a crisis safety plan with mobile crisis, and the next day, that follow-up care was provided by that person's therapist. The therapist kind of determined that the person still seemed to be struggling and encouraged them to come into the office for a walk-in therapy session. And the person agreed to come in. When they arrived, after some further evaluation, it was determined that they needed a higher level of care and that a stay at a crisis residential unit could be very beneficial. Without that follow-up, again, after that mobile crisis response, that person could have decompensated and not received the treatment that they needed in a timely manner, which helped them get back on their road to recovery. So responding to a crisis is critical. You can see just in 2 of those examples, and there's so many more. But what happens after that moment matters just as much. Following up with someone after that crisis can be the difference between continued stability and falling back into a crisis. And it helps reinforce for that person that they're not alone and that someone is there and that their care did not end when the immediate situation was resolved. We all know that mental health is nonlinear and the road to recovery is nonlinear, which is why that follow-up piece is so very important. So from those examples, I hope you can also see the roles of peer support specialists and follow-up. It's not just valuable. In my personal opinion, it's essential in follow-up. It helps build relationships, it helps reduce isolation, and it helps our Mississippians stay engaged in their recovery journey. In Mississippi, one way we are doing this is also through peer respite programs. Peer respite programs are voluntary, short-term, overnight programs that provide community-based, non-clinical crisis support to help someone who's experiencing or maybe just at risk of experiencing a crisis. And in our state, our peer respite programs are doing a phenomenal job. We have one on our Mississippi Gulf Coast who had someone recently come stay at their peer respite program. And because of the support in their crisis and the follow-up that they received, they decided they wanted to start their own path to becoming a certified peer support specialist, and they've now gone through the training. So it just shows you how you can carry on after that follow-up care and then even become part of the system to provide that support to other people. So in Mississippi, we know that people with lived experience can bring something that no clinical model can fully replicate. They bring understanding and they bring trust, and most importantly, they bring hope. So that's why we feel like making sure that peer support specialists are part of our follow-up system is so important. We also do this through peer bridgers. So we have peer bridgers who work at our state hospitals. They go through the certified peer support specialist training, and they go through specific peer bridger training as well. They work at our state hospitals and they work at the community mental health centers. And they're exactly what it says, a peer bridger. They bridge someone who's leaving a state hospital back into their community or leaving a crisis residential unit back into their community. And that transition can be one of the most vulnerable points in someone's journey. So having someone who's walked that similar path alongside them can make all the difference. You can see that there are, in our peer bridger program, you can see the impact of these connections. You can move to the next slide. In our peer bridger program, we have 72% of individuals who are discharged from a state hospital made their initial follow-up appointment with a community mental health center. So because they had that follow-up care and that care while they were transitioning, 72% discharged from the hospital made their initial follow-up appointment, and they were connected with that peer bridger. So that's a strong indicator that people are staying connected to care after a crisis and after an inpatient stay if they have that follow-up care with a peer bridger. But ultimately, follow-up is not owned by just one part of the system. It's incumbent on all of us. It's every provider, every partner, every touch point to make sure that when someone enters care, they're supported all the way through. On this slide, you can see just a few of the initiatives and projects that we're working on in Mississippi to help strengthen that follow-up care. There are two specific sources of funding that we are going to be using as we move forward in the future. Rural Health Transformation Funds and Opioid Settlement Funds. But at the heart of all of these initiatives that you can see on this slide is follow-up care. So we have psychiatric emergency services that we are going to be launching and starting in our state this year and over the next 3 years, which would be 24/7, no wrong door, psychiatric emergency service that are connected with a hospital to stabilize. But also part of that is follow-up care and peer support after the immediate crisis. We're looking at telehealth expansion and how to build in follow-up care with telehealth expansion in the state. With our crisis continuum, we're looking at closed loop referral systems that are built with a very strong follow-up care at the core. Looking at strengthening care coordination at all levels within the crisis system. We're also looking at expanding living room models and diversion centers that are partly a crisis residential and then also have a living room model. And with those will be standards for follow-up care and the use of peer bridgers. We're also looking in our state at a statewide HIE, which would help connect all the dots and again, ensure that that follow-up care occurs. It's a lot of work that's being done, a lot of work that's been done. And I will tell you it's because of a phenomenal team. Brent Hurley, he is our director of the Bureau of Crisis Response in the state. Jaquilla Newsom with our 988 efforts and our 2 988 call centers. Cambria Thorne who works with our crisis stabilization units and our mobile crisis response teams, and Angel Riley, who's our care coordinator for across the system. We know that you have to have that strong team, you have to provide that support, and they have to be passionate about what they do. And I think that's why we've been successful in our state. And we've got providers who understand. We have operational standards. The Department of Mental Health has operational standards. And within those standards are follow-up requirements. But it's not just on paper. And that's the difference. You have to have people who are passionate and who understand that the follow-up is needed, important, and just as important as the crisis care that's provided. So this helps us improve access and stronger connections, and then overall healthier communities across our state and across our nation. So in Mississippi, we do not want to stop at stabilization, even though it's very important. We want to stay connected for recovery and be a part of that recovery journey for someone. And that includes their follow-up. So now next slide, I'm sorry. And now I'm going to pass it off to our next presenters, Jennifer and Teresa with the state of Utah.
Thank you so much, Wendy, and hello, everybody. My name is Jennifer Hebden-Selyestead. I'm the Crisis Administrator for the state of Utah with the Department of Health and Human Services. I'm proud today to introduce one of our community partners, Teresa Lopez, LCSW. Teresa is the Program Director of the Behavioral Health Integration Program and has worked for over 15 years at the University of Utah and Huntsman Mental Health Institute. Teresa has degrees in psychology, neuroscience, and social work. Her specialties include implementation science, addiction, sexual assault, intimate partner violence, EMDR, women's health, autism spectrum, and compassion fatigue. And Teresa has played a central role in integrated care's growth and development across multiple clinical settings. Specifically, she's supported the implementation of the You Matter outreach program, the collaborative care program, and a universal mental health screening program. So take it away, Teresa.
Thank you so much, Jennifer. Just wonderful conversation and so interesting to hear from all the states today. Honored to be here. Wanted to give a shout out to my colleague, Kevin Curtis, who has been an essential partner in this work. And today I'm going to walk you through what our You Matter outreach program is and what we're focusing on. So next slide, please. So few objectives today, but overall, we're going to talk about kind of operations, how our program works, how we started it, what it took to build it, and most importantly, what we've learned and lessons that maybe you can apply in your own settings. So next slide. We have grounded this work in the zero suicide framework and really the idea that suicide prevention is a system responsibility across the whole academic medical center, not just an individual provider responsibility. And everyone on this call is here because we know that that is a critical risk period for our individuals after they discharge from a mental health crisis. So next slide. So the core problem, like I said, we know suicide risk is the highest in the weeks after discharge, whether that's from an emergency department visit for a mental health crisis, an inpatient psychiatric stay, or just a crisis care interaction. Traditional systems have relied on the patient to follow up, just been given discharge instructions and they're on their way. But what we wanted to do differently at University of Utah Health and Huntsman Mental Health Institute is to flip that model and proactively reach out during the highest risk window. So that's really the purpose of our You Matter program, is closing a known high risk gap in care. Next slide, please. So program structure, we'll walk through what it actually looks like. Next slide. So who we serve patients age 10 and up who present with a suicide-related concern across our whole system of care, from our emergency departments to our crisis care center, receiving centers, and inpatient psychiatry. And our goals are pretty straightforward. We wanted to reduce suicide risk after discharge, reduce readmissions, and ensure that our patients actually connect to the follow-up care that's provided. Next slide.
We have run this program through a grant from the state of Utah with just two FTEs of behavioral health case analysts that are bachelor's level, plus support from our primary care social service workers. What has made this program effective is a structured, proactive approach. So we contact patients at 4 different intervals across 3 months. And the focus is not therapy, it's connection, it's safety support, it's helping with care navigation. This is a bridge model. We're not replacing clinical care, we're making sure that patients actually get to it. Next slide. Okay, so how did we build the program? Next slide. It took a strong partnership across multiple groups, even though we're part of one system of care. We had to bring together our crisis care center team, our zero suicide initiative teams, our team with integrated behavioral health in primary care and specialty care. And we also brought in insight from our quality safety teams and through value engineering. This wasn't built in isolation. It required alignment across multiple systems regarding our reporting and population identification, our workflow design, and our staffing infrastructure. Next slide. So a huge enabler was how we built this into the electronic health record. We wanted to create processes that were as automated as possible. And so first we created trigger points that included if someone was admitted for an emergency department visit for a suicide risk concern, crisis encounters, or inpatient psychiatric discharges. Those are the inclusion groups. And then the logic identifies the eligible patients and routes them. So a key piece that we did with our model is broke down the workforce into 2 different groups. If a patient already had a primary care provider in our system, then they would be managed by the embedded social service workers that already work in those clinics and have those established relationships with those teams. And if not, they would go to our You Matter outreach team. And that segmentation was really important for efficiency. Next slide. So a few things that made this work operationally. First, we integrated warm handoffs whenever possible. So that meant even prior to discharge, our staff are coming and introducing themselves to the patients, establishing that relationship, letting them know what to expect from the follow-up calls. So that initial rapport building is really essential. Then we had the structured outreach cadence. And within that, we had ongoing suicide risk assessment and safety planning. A big piece that we implemented that was really helpful was all of our staff, whether they were social service workers or case analysts, went through the Utah Certified Crisis Worker Training, and that really gave them the skills and the tools to be able to help support individuals no matter where they are after their initial crisis and on their journey. Next slide. Okay, so this illustrates that call and outreach workflow in practice from discharge through outreach and connection to care. So a few things I want to point out in terms of best practices in our follow-up calls. First, we use the ASQ to assess suicide risk on every call. Second, we follow up with the Stanley Brown Safety Plan. Most of the time that's already been established on their inpatient stay. So we can reflect that's written in the medical record and or establish a new safety plan if needed. And then we also integrate counseling on lethal means. So besides that, we're following up on medications that were provided, the care coordination, and then the next steps for patients. Next slide. So now I'll shift to outcomes. Next slide. So we've seen really strong results reconnecting patients, and part of our foundation has been connecting them back to primary care, where they really have that integrated team-based care in the community clinics. And so we've had 260, this data is a little older, so I'm sure it's much more than this, patients that have completed primary care follow-up, and then over 330 patients that have completed follow-up visits with a University of Utah Health behavioral health provider in our system of care. This program is not even a year old, so pretty fantastic results, and we're really glad to see people going back to primary care. Next slide. And these are more metrics that we are tracking. So we're looking at month over month, how many patients are eligible, how many we actually reach, the number of suicide risk screenings completed and the results of those, and our successful linkages to care, like I discussed in the previous slide. Not only was this a requirement of the grant, but we have to have clear metrics to help us refine and justify the program going forward and making sure that we're accomplishing what we set out to do. Next slide. So at scale, we've completed well over 2,600 meaningful contacts, which has supported probably over 4,000 patients at this point. Our reach rates are around 35 to 40%, which is something we're trying to improve, but it's pretty consistent with national benchmarks. We are looking at innovative ways to reach patients besides just the telephone calls and the electronic health record messages, such as text messaging. So we're looking forward to launching that in the near future. But the most impactful data here is looking at among patients that have been in crisis, the hospital admissions dropped from 44% before engagement to under 5% during the program. So that's both a safety outcome and a cost outcome for our system. Next slide. And the real impact, the qualitative feedback. These are just a few examples of feedback from patients, and tell you about one of my favorite examples that my team's heard about before, but it was early on when UMatter had just barely launched, and it involved a patient that was reached at the 48-hour call 2 days after discharge. They answered while they were out in the community, and they told the person on the call that they were actively in the process of carrying out a suicide plan. Because the outreach team reached the patient in that moment and were able to establish rapport, assess risk, and discuss with the patient what the next steps were, they decided to activate EMS. The patient agreed to voluntarily be safely transferred to a higher level of care. So that really meaningful example of, and real example of how these calls meet people in real life, and sometimes at the exact moment that safety hangs in the balance. Next slide. So where can you start if you're looking to mimic a program similar to this? Next slide. Here are a few key lessons. The people. Just like has been discussed with the other states, you want to hire the adaptable people that are compassionate and have the mindset, and that really matters more than role history. You can expect the program to evolve and build training around both the workflow and the relationship skills. Operationally, you want to define your population early. You want to work with your electronic health record analysts and build that workflow early, and then create strong task management systems. Next slide. Some operational realities just to level set. Reach rates will most likely be lower than you want. It will take multiple attempts to reach patients, and there's ways that you can adapt and innovate over time with different ways of reaching out. Workflows will need constant refinement. But also, this is incredibly meaningful work. Our teams that are doing this work consistently share when they've made a successful, contact with people, when they've done a 3-month outreach and they hear that someone has been, sober for all that time and doing well. So, as mentioned before, it takes a real strong team, and I'm really grateful that I've been a part of this journey with so many amazing stakeholders in this. Next slide. So thank you, and happy to connect if you have questions or want to talk about implementation in your setting. Grateful for this opportunity, and now I'll turn it back over to Dr. Sims.
Man, Thank you. Thank you all. Thank you to all three of the states for this marvelous presentation. I have to say, it's a challenge to present such detailed information in a short time frame given. So let me first thank you all for your wonderfully focused descriptions of post-crisis care. You know, it's been said that when you see one state, you've seen one state. So let me just thank you for your individualized approaches. That gives us a lot of information to be able to work with when we're trying to construct our own systems in the various areas we live in. I want to go through the next couple of slides just to bring you up to date that any recordings, now we've done these state peer-to-peer learning sessions, and I do want to make you aware that they are available on the SAMHSA site at the address that is listed there. I think there was something in the, a question raised in the chat box about this recording. And just a reminder that a copy of this recording will be on the SAMHSA site in the very near future. So you're able to also get that, but just if you'll focus on this particular one about assessing previous learning sessions, you can get this and many others before that. Next slide, please. And SAMHSA values your feedback. So here you have a QR code, and me being the grandfather age now, the QR code's kind of a new thing for me, but here you are able to evaluate today's session. Now, this code will be posted at the end of this session, so you'll have time to be able to use your cell phone and get the QR code. We're just bringing it up that we really value your evaluation of how today's session has gone. Also, by this, we'll see that the link will be placed in the chat as well, and it's already there. Next slide, please. And in looking at the whole function of the state's TA project services, the technical assistance project services, you are able to access them through the link that you see on the board there. So to request any technical assistance, please visit what is listed, and you'll be able to access what available services are there for your individual needs. So please don't hesitate to get in contact with them. And again, this information will also be in that packet that in the resources as you look at these presentations in the future. And with that, I think we'll move now to taking a look at our question and answer period. This is going to be a fun time, I tell you. While you, all three of you were, or four of you in this case, were giving such stellar presentations, there were a lot of questions that were placed before me. I hope we have enough time to get through them all, but we're just going to see how things work out. All righty. So if you all are ready, I'm first going to actually kind of tease out Illinois, if you don't mind. So Allie, a question was raised about any information you might have on how you gave such a very detailed description of the services, but what do those services kind of look like in your community? Do you have examples or anything you might be able to share about how it's been implemented?
An overview of our crisis services or the services covered by the new Medicaid rate, or all of the above?
Well, yeah, it's kind of all of the above, but we're really looking at putting a face on the services. I mean, how does it
Sure.
look for the people that are receiving it?
Yeah, for sure. So, and I will do my best to focus on the follow-up elements. But in Illinois, we have 988 and mobile crisis truly statewide that are 24/7, 365. The state funds mobile crisis response teams through a grant and also through increasingly Medicaid funding. With our fantastic providers all around the state. And those teams are made up of a peer and a crisis counselor that's a mental health professional. And it looks a little different depending on what the organization is, where you are in the state. Those individuals could be at a set location waiting to go. They could be waiting to go from home, right? And they go out. The idea is to meet people where they're at in community, or we also have calls from hospitals, other places that they can show up. And then in terms of places to go, we have living room programs that are state funded scattered around the state that are totally peer run, 24/7, also 365. And those are places that are home-like environments where people can go and rest, interact, as I know has been really highlighted with that all-important peer, really understands and can help you safety plan and figure out what's next, or even just rest and sleep it off, get a snack, get a hygiene kit, and figure out where you need to go. And is also a place that if a more traditional first responder sees someone in need and thinks that jail or a hospital isn't right, a living room is always there as a place where those folks can go and have a really warm welcome. And also an important part of that follow-up planning, right, of knowing those places to go, those numbers to call that are 24/7, 365. It is both a challenge, and we are very lucky that we are building out these programs statewide through our state Medicaid Authority and us at the Division of Behavioral Health and Recovery, because we are also under a statutory mandate to have 24/7 behavioral health crisis response ready to go and available through 911 by July 2027, which means that you have to start with making sure that you're building out the services to connect. And we have lots of great services available already and lots of providers doing that work for a long time. And we need to make sure that all those pieces are talking to each other and then figure out how to make them talk to 911 as well.
Oh, that is so wonderful. Thank you for drilling down on that, because it really sounds very comprehensive. The services really sound like they are wonderfully placed, and all three of the states have just given that kind of information that really makes you feel comfortable about the delivery of service. Now, there was a statistic that was placed, or a question that was asked in the chat box about the number of 988 call takers. And it just kind of triggered a question in my mind to throw at all of you. They gave the answer for Mississippi, but I'm curious about the balance between the number of call takers and the number of calls. Do you have an idea of what that balance might look like for your states? And Ali, not to put you on the spot, but I'll ask you first.
Yeah, I will say I don't know offhand exactly how many
Mm.
call takers we have, but we do have 7 call centers. And I was just looking at our main numbers today. We answered about 14,000 calls across
Wow.
those
Wow.
centers, and then answered about 40% of the chat and texts that came into the state. So that's still capacity we're building up. We are very proud of our call centers and our incredible crisis counselors who do really important, compassionate work to help people in some of their worst moments, and are always working to build that capacity more, and very aware of burnout and turnover and compassion fatigue, all those things I know we all talk about when it comes to workforce. Because again, you are sitting in a room hearing people at some of their worst moments, and we don't want every call taker at their exact most effective capacity of exactly how many calls they can answer in a shift. They need downtime, they need support, they need places they can go to decompress and access to mental health resources for themselves, to make sure that we're not overburdening them, asking them to work overtime to make sure that the phones and the chat and text are covered,
Gotcha.
and always trying to figure out how we can more sustainably. And I think that's part of why my presentation focused on financing, because I was getting into a bit of the nitty gritty on numbers, right? And at the end of the day, we need all that money to make sure that we aren't putting less pressure on the people on the ground providing the services, getting in the van at 2 a.m., picking up the phone at 5 a.m. to make sure that there's enough of those people that they can also have a healthy life and boundaries and aren't facing burnout, because we want to make sure that those people stay in this line of work. And then we continue having more and more experienced call takers and chat takers that can then move into supervisory roles and mentor other folks. And that 5 years from now, 10 years from now, they still want to be working in that call center or running their own call center.
Beautiful. Thank you. Thank you. Wendy, what about Mississippi?
So we have 2 call centers and approximately about 50 trained crisis counselors that answer those calls. We had about 17,600 calls last fiscal year. This fiscal year that we're currently in, though, by the first 6 months, we were already over 13,000 calls. So by knowing that, that's kind of where I was talking about. We're seeing about a 20% growth each year. Our trained crisis counselors are fantastic. I can tell you one thing that we have learned is they're 24/7. So sometimes it's difficult for people who are in that 24/7 process to be able to participate in training. But we purposely this year we had a crisis conference for the state, and we're going to bring in some IDD, dual diagnosed training for our 988 call centers, but making sure that they do have that opportunity to participate in training too. Helps also with what Allie just talked about with burnout, because they are experiencing all of these crises with each person. I mean, when we say 17,600 calls, that's 17,600 people. And that's what we can't forget, is that behind every one of these numbers and every one of these statistics, all the great outcomes that Teresa talked about, it's a person. So we want to make sure that they have someone to answer that call. We have, and I got to brag, because, Mississippi often is not at the top of a lot of things, but we are, with our in-state answer rate, #1 in the nation, again this month too. And we have an average answer response rate of 1.1 seconds.
Oh,
But also we know that as the calls grow, in order to be able to keep up with that response rate and to be able to keep up with that in-state answer rate, we're going to need more trained crisis counselors. So we had our legislature this year. We had some ARPA funding in the past that we were helping provide to the 988 call centers, and our legislature this year funded it through general funds since ARPA is now ending. So we got $1.6 million to be able to funnel to those 2 988 crisis centers to help build up the crisis counselors they need, and also to help build up our text and our chat responses as well.
Wonderful how it's evolving. I really love that progression. That is great. Well, how about Jennifer and Teresa?
Yeah, I'll take this, Teresa, if that's okay. Utah, I'll brag also, Wendy. I'm just as proud of Utah and our crisis services that we've set up. In Utah, we have one crisis center, and it's through our community partners, Huntsman Mental Health Institute, it's the University of Utah Health System. I don't know exactly what their staffing ratio is, but they answer, not including for this fiscal year, state fiscal year, not including June data, they've answered over 57,000 calls for the entire state. That's not including chat and text, and consistently maintaining above 90% answer rate. So really doing a lot of great work in the state, covering the whole state, including in the rural areas down in southern Utah, and those areas that sometimes are hard to reach, and some tribal nations and such. So we are now 100% covered for 988 crisis services throughout the state of Utah.
Thanks. Outstanding.
Yeah.
Well, thank you all for fielding that question. I did have, however, I wanted to go backwards, if you would, because I think one of the questions that was looked at is, you all are presenting these wonderfully organized and successful initiatives, and you can see their effectiveness. I wanted to go backwards to have you identify when you first started this. What kind of challenges did you come up against? Because I'm sure those who want to start the system would be very interested in finding out what you may have come across and what they might have to look at as far as implementing it on their own. And anyone can pick that question up. I'll just leave the floor open.
Well, I'll jump in and say I wasn't here in the beginning. I was able to pick up this program from a very valued colleague and the crisis team that is here with us now that does amazing work. But definitely staffing in the rural areas of the state is incredibly difficult for master's level clinicians, peer support, case management. So for us, that's been the most difficult journey to make sure we find competent individuals to staff crisis services, whether that be receiving centers, MCOTs, 988, all of that.
Yeah, I'll jump in and second that. I also got to pick this up after the initial push was done, and very grateful to my predecessors and current colleagues who looped me in on all the things that happened before I was here, when I just got to accept an already won 988 grant. And I think those differences across the state are similar for us. We have a really wide range of resources and population density and needs across our urban, suburban, and rural areas. And so how long it takes to get from point A to point B, right? And how quickly we can get places, if it's more likely that it's easier for someone to staff all starting from the same place versus for your home. All those things, especially about mobile crisis services, are really different depending where you are. And because we're trying to build statewide, working with our really fantastic and creative and passionate providers to figure out how we maintain a consistent level of service while also price and modification local needs is a consistent push and pull.
Awesome.
For us, we have 82 counties in Mississippi and only 3 are urban. So going back to what Jennifer said, we are a rural state. So difficulty with transportation is often an issue with a crisis service. That's where we really have tried to bring more awareness to 988, because that's a call that you can make, and then the mobile crisis can come to a physical response wherever you're located. So one challenge was just awareness, making people aware of the services. The second challenge is that transportation, which also plays into the workforce, like Jennifer mentioned. And it's also making sure that the workforce is adequately trained. I mentioned earlier about additional training, but in our state, one of the challenges that we have is dual diagnosed people with intellectual and developmental disabilities who also have a serious mental illness or who also have a substance use addiction problem. And many times staff may know how to work with people who have behavioral health, but not necessarily IDD. And it is very different populations. So making sure that the people in the crisis system understand how to provide those crisis services to everyone, no matter the individual or what the crisis problem is. We also ran into a little bit of a barrier, and this is a good thing because it shows that our providers are invested in their community. But when 988 first started, we had mobile crisis. We had mobile crisis 24/7 in all 82 counties. And our community mental health centers who provide those services had built good, strong relationships with the community. And they had a mobile crisis number for people to call. So kind of shifting to, we were promoting 988, the 3-digit number that everyone could remember, while still knowing there was mobile crisis in the communities as well. That really led us to try to build good, strong partnerships between the mobile crisis teams and the community mental health centers and the 988 call centers, to where 988 could dispatch out, but also have an understanding of why we are encouraging people to call 988 first, but also keeping those local community connections, especially with law enforcement, who often calls mobile crisis response. So that was a barrier in the beginning, and we've been able to work through that with some strong protocols and just communication.
And it's just incredibly helpful information, because I'm sure those that are looking at startups. Let me just ask you all a question. If you could just phrase it in whatever way you wish, what would you say to states that don't yet have their system set up for follow-up in the way that you do? What would you say to them to encourage them?
I would say, and I mentioned this in the presentation, that it's essential. You have to look at the follow-up part of the crisis system is absolutely as important as the crisis response. Making sure that you know that that individual is engaged and trying more than just one time to make sure that that follow-up is occurring will bring relief on the crisis system side. Because if you are ensuring that follow-up happens and you are ensuring to the best of your ability that the individual is getting connected to the resources that they need, and again, going back particularly to peer support, you will prevent another crisis from occurring. And that's where you can see your outcomes. I mean, when I saw a question over here too about how do we measure the effectiveness of the post-crisis?
Right.
You measure that effectiveness by reoccurring crisis and being able to see where you've got a decrease in hospitalizations and a decrease in ER visits and a decrease in crisis residential, and then an increase in your follow-up appointment and an increase in your engagement levels. So it's really, you have to understand, and that's got to come from the top down throughout the entire system, that follow-up piece is just as important of an investment as your mobile crisis and your crisis residential and your 988 call centers. And you have to have it embedded throughout the entire continuum.
Well, I can jump in, and maybe this is just a brief summary of what Wendy already said, but really, if the states are looking at improving total cost of care, they have to identify ways to strengthen our transitions of care for behavioral health patients. That's just the glue that's essential in this, and we really can demonstrate those decreased cost outcomes and improved, follow-up care afterwards.
Outstanding.
Well, Wendy and Teresa said everything fine. My only addition is think about how you're going to make sure that you're funding your providers, your local governments for follow-up so that they can really build out the capacity to do it. And it's not the same person who's in the van trying to get to the crisis call, also making a call to do both to make sure they get through both at the same time.
Outstanding. And again, as we go through these questions, they help to really formulate, I think, for those that are looking at establishing systems, that there's a front door and there's a method and there's an outcome. So again, thank you all, because it's so orderly in the way that it's been presented. I know that a lot of times there are questions that are raised about different levels of care. And I want to go to a question that was in the chat box from Judy McNutt. And I'll just read it the way that she put it there. How can Utah's program, and I guess this could be something not just for Utah, but just looking at all of your states, how can Utah's program be expanded to somehow include release from prison for clients receiving mental health care while incarcerated? And they're looking at it from the lens of a lot of times release from prison is the crisis. So
well, is that
in
relation to if the individual is still in crisis when released, they would go then to the receiving center and that sort of thing. So it's really hitting the receiving center bucket before hitting, the follow-up piece. And I don't know if Kevin Curtis, who I think you're all very familiar with, is on this, and he runs our receiving center, our biggest receiving center here in Salt Lake County. But they would evaluate typically that individual for care in the receiving center and bring them in if needed for services.
And just to throw another piece in there, I think she was also looking at if there was any implementation of services while they're still incarcerated that kind of leads to their release.
That I'm not familiar with. I don't know if Kevin wants to come off mute and answer that in relation to his receiving center, what kind of work they do.
Hey, Kevin.
Sure. Thank you for letting me crash this. All of the presenters just did such an amazing job talking about these innovations. Both our county jail and our state prison structure, they do have structured mental health services involved while people are there incarcerated. The state has made kind of major investments in it. Recently, there's been a change in state Medicaid rule to allow for people not to lose their Medicaid status when they go into jail and prison. And that's really facilitated improving the quality and the availability of that care. So I work very closely with my jail and prison mental health colleagues, and they do a quite good job of caring for people while they're in those settings. And they've actually developed pretty good processes for kind of setting up follow-up care and getting them out. Where our system struggles to meet those needs is when the process of judicial release happens in an unplanned way, and you get that person that maybe has been going through competency restoration, has not been restorable, and is released in a state of kind of lack of stability, or in a way where all of those processes can't be planned and implemented. And so we coordinate multiple times a week around having those people transitioned directly to our crisis center, where we can evaluate, start the stabilization process, and then work with many different partners in terms of appropriate care connections for what each individual case needs. So I wouldn't say that this was a primary design kind of thing that we intended for our crisis center to do, but what we've learned over the many years of journey of being a part of this larger crisis system is create systems with capacity and with flexibility. And as you build each part of this process incrementally, it just illuminates the next part of the development process. And I'm not sure we'll ever be done building and improving on our crisis response system. But if you build the capacity and the structure, and you sort of kind of build these partnerships, you can find these ways of leveraging these systems to fill some of these gaps, like the one that's been mentioned on in the chat around the jail and the prison partnership.
Well, Kevin, first of all, it's great to see you and hear from you. But I love that last point and wanted to push it out there that these programs that you all are presenting are really evolving. They're works in progress and they are continuing to grow. And that's the optimistic piece that all states should take a look at in terms of implementing services, because as Wendy has pointed out earlier, the critical nature of follow-up on this has so many implications that can come back and help your system to save money, to be able to really improve the quality of life for people served. But thank you so much, Kevin, for that. I don't know if we're going to take you off screen, but I can tell you, you can stay on as far as I'm concerned. But to all of you, we're kind of coming down to the close of our question and answer portion. I just wanted to challenge you all in just a brief moment to just give some comment in a summary way. If you wanted to say anything to these group of people that have been listening to you throughout these presentations, what would you want to leave them with as far as a final statement from your specific state? Now, give you a moment to think on that one, because I'm known for throwing curves here, but
Okay, I'll go first.
Please.
We do not have it all figured out, trust me. So when you sit and you listen to these presentations, because I was thinking about the things Illinois and Utah, and you gain information of what you can do or what you can do differently. No one has it figured out. No one has it working perfectly across all areas in their state. But you can't always be striving to make it better. And I think that's the key for us to remember. I tell my staff all the time, yes, we got a call about this problem or this issue, but we didn't get the calls about everything that went right that day. And that's what's happening in the crisis system across the nation. When you look back that it's only been a few years since 988 changed to 988, what has occurred in such a short amount of time is incredible. And what's changed in states in such a short amount of time is incredible. And the emphasis that's placed on the entire crisis continuum. So my advice would be, we have lots of gaps, we have lots of problems, and we have a lot of things that we still need to address. But you address it, and you address it each and every day. And you glean from your other commissioners and crisis directors from other states. And you work together on that, and just stay in that communication where you're not alone either. You're not alone in trying to fix the problems, just like the person that's in the crisis system is not alone in the care that they need.
Outstanding. Thank you so much, Wendy. So, Ali.
Again, double click on what Wendy said. And from my side, I think I'll add, transition is hard. We all know that. Building a crisis system that works for everyone every time and gives everyone the follow-up they need is hard, especially when, as behavioral health folks, we want to give people the thing that's the exact right fit for them, which is not always how system building works. And so as you go into system building, making sure that you're thinking about follow-up as part of the service that you're trying to provide your residents, not as an afterthought, in terms of funding, in terms of planning, in terms of really at the core of this work, and then giving everyone involved grace as you work to implement and figuring out how to adjust, because we are really trying to figure out how to make a really flexible service with really difficult streams of funding. And I can say, at least in Illinois, restrictions on how we can build. And that's hard when you're trying to provide compassionate, consistent, sustainable, equitable care.
Those are beautiful. And if I could say anything different, for those that are looking at, trying out some of these systems or creating their own, just continue to innovate, continue to think outside the box, to reach out to partners across multiple states, and kind of come with that experimental mindset, use those PDSA cycles and just continue with that innovation and continuous quality improvement mindset. And it's a fun adventure too. I mean, we're saving lives. So that's what I have to add.
Well, all of you beautifully said. Thank you so much. Thank you for your presentations. Thank you for everything that you're doing in this space. So at this point, I just want to pause and say thank you again to each of you and to SAMHSA for their continued leadership and support. And thank all of you for your participation in today's discussion.